So everyone, thank you very much for your interest in this and in our other upcoming webinars. This is the first of 3 introductory webinars that SAMHSA is hosting over the next 3 months that are related to the behavioral health clinic quality measures. These are in the process of being updated from their 2016 iteration, and I expect the technical specifications to be released by the beginning of September. I'll talk more about the schedule for reporting, along with providing information on later webinars that we plan to host after we release the technical specifications. But the primary focus of this webinar is to introduce quality measurement for CCBHCs and the CCBHC IAs and PDIs. So we have a broad spectrum of audience today. I am Peggy O'Brien. I'm part of the SAMHSA Center for Behavioral Health Statistics and Quality, or CBISQ, Office of Evaluation. First, let me address some logistics. We are recording this webinar and closed captioning is provided. The slides, a transcript, and the recording will be available about a week after the presentation and will be posted on the SAMHSA CCBHC website for everybody to access. We have a large number of people attending this webinar, and so we have asked that you please mute your lines. I think we did it for you, and turn off your cameras in order to preserve people's internet stability. We'll have time for questions at the end. Please feel free to put questions in the chat as we go, and we'll address them at the end using the questions in the chat. And before I dive into the substance of this webinar, I want to thank the following people. Shweta Palakode, also at the CBISQ Office of Evaluation, who has been very helpful in preparation of the slides I'm sharing today, and who will be trying to decipher the chat at the end to pass along questions. The CCBHC SAMHSA team and the Center for Mental Health Services, CMHS, who are always a pleasure to work with. The National Council for Mental Wellbeing for responding to my repeated requests for contact information, good dates for webinars and everything else, and AG Associates, the CMHS logistics contractor. So this is today's agenda. I will start with a general introduction to quality measures just to make sure everyone has a very basic grounding. This will be material that some of you are extremely familiar with, but many are not. So I want to just lay out a groundwork for you. Then we'll move on to the role of quality measurement and CCBHCs. I'll introduce both the clinic collected measures and the state collected measures and discuss timeframes for reporting the new or updated measures. I also want to let you know a bit about the future webinars and who should attend. Then we'll have time for questions, which will have to be from the chat, given how many people we have on the webinar. So I do want to start with a quick poll to determine who is in the audience today. So please select the options that accurately describe your role. I know that for some of you, multiple choices may be appropriate, so you can select more than one response. So are you here on behalf of a potential CCBHC demonstration state, an existing demonstration state, a potential CCBHC demonstration clinic, an existing clinic, demonstration clinic, an independent state CCBHC initiative, CCBHC PDI grantees, CCBHC IA grantees, or other? And feel free to identify your role in the chat if it's not listed above. So I'm going to wait a minute for people to complete this poll. Selby, if you could just let me know when we have a critical number of answers, we can take a look at the responses. Okay. Oh, here it comes. We're creeping up to around 415 responses so far. So let's give it another few seconds. Okay. We're getting there. We have 82% so far. I really want to see what the results are, so I'm going to wait. Okay, I think it's slowing down. Selby, should I end the poll or do you do that? Okay. And share the results. Should I move this to the other screen, Selby? I'm going.
However you want to do it, it's fine.
Okay. Yeah. You can tell we practice this a lot. Okay. So we have a pretty good distribution. We have potential and existing demonstration states and clinics. A little bit of a few independent state CCBHC initiatives, but the majority are the PDI and IA grantees, and that's really great to hear. So thank you very much for completing the poll, and that was with 83% of you participating. So I'm going to stop sharing that. And make it go away. Okay. All right. All right. Okay. So the intended audience for this webinar is really broad. It is prospective and existing CCBHC demonstration staff in state agents, Medicaid agencies and CCBHCs, independent state initiatives, and the expansion grants that are PDIs and IAs, as well as SAMHSA government program officers. This is a general webinar. So as we move into webinars with greater specificity about certain topics, I'm going to try to let you know who's best invited to those. I also want to specifically note that for SAMHSA grantee clinics that haven't been part of the existing demonstration and haven't been reporting quality measures in the past, I'm hoping that these general webinars can be a sort of gentle introduction to quality measurement and what it means in the CCBHC realm. We realize that this is new for many of you and that you also are reporting NOMs and have had a lot of recent adjustments in those tools and the sampling methodology. We do want to make this as easy and understandable as it can be for you. Additionally, for clinics in states that are hoping to join the demonstration and for those states as well, these webinars are intended to help get you ready. Okay, so what are quality measures? This is the definition that's provided by the Centers for Medicare and Medicaid Services, or CMS. Quality measures are standards for measuring the performance of healthcare providers to care for patients and populations. And what is the purpose of quality measurement? I would say that generally it falls into these three primary categories. To measure the performance of healthcare providers, healthcare systems, or insurers, to inform quality improvement initiatives in healthcare settings, and to compare performance of providers over time or performance across providers. As you'll see, though, when I talk about why we use quality measures for CCBHCs, not all of these reasons have equal weight, and I'll get to that in a little bit. Some other basic information, though. The Agency for Healthcare Research and Quality, or AHRQ, identifies three types of quality measures. The first is structural. This measures a provider's capacity, systems, and processes to provide high-quality care. An example that I have here on the screen is adoption of e-prescribing of medication. That is not one of our measures, but I needed a structural measure to give you an example. Process measures. The second kind are by far still the most common. This looks at what a provider does to maintain or improve health. An example is the measure of follow-up after an ED visit, and that is one of our state measures. And lastly, outcome measures are still dismayingly rare, but they look at the impact of the healthcare services on the health status of those receiving services. An example of which is the measure of depression remission at 6 months, which is one of our clinic collected measures. So I apologize for anyone who doesn't like math, but I just want to show you in a very simple form how a quality measure is calculated. The rate is a percent with a numerator and a denominator. And that's basically the number of people meeting the standard for whatever is being measured over the total eligible population. The next slide shows an example using one of the real state collected measures. So here, the rate of 7-day follow-up after an ED visit for mental illness equals the number of follow-up visits within 7 days of a relevant ED visit, divided by the number of ED visits for adults and children 6 and older with a diagnosis of mental illness. Of course, it's not really that simple because all of these components have to be clearly specified for uniform calculation, which is where the technical specifications and our fall webinars will come in. The last bit of general information I want to share is just that there are 3 general types of data that are used for quality measurement. Administrative data is data such as Medicaid claims or encounter data. Medical records data can be paper or electronic medical records. Increasingly, other forms of electronic information or digital information, such as scheduling software or a registry. And then finally, survey data, such as surveys of patient or family experience of care. Some increasingly small number of quality measures may be hybrids of these, but those are far less common than they used to be. So I think that's probably sufficient background just to get us on a level playing field. I want to spend the rest of our time talking about how quality measures relate to CCBHCs. There are several reasons why Section 223 CCBHC demonstration states and clinics, as well as the clinics that are part of the SAMHSA PDI and IA grants, are or will be reporting quality measure data. First, for the demonstration states and clinics, the authorizing statute for the CCBHCs requires reporting of encounter data, clinical outcomes data, quality data, and such other data as the Secretary requires, and that's the Secretary of HHS. Second, for everyone, the CCBHC certification criteria, which were updated in March of 2023, echo that requirement and provide additional detail about what is required. And that is for everybody. And then last, but definitely not least, for everyone, quality measurement facilitates quality improvement and evaluation. And for the demonstration CCBHCs, it is the foundation for your quality bonus payments. So looking at this most simply, there are 2 broad sets of quality measures related to the CCBHCs. There are state collected measures, and they only apply for the demonstration. And then there are clinic collected measures. The existing demonstration states and clinics have had to report since the inception of the demonstration. They started in 2017. And new demonstration states and their certified clinics will also be required, as will be the SAMHSA CCBHC, IA, and PDI grantees. So this kind of busy slide shows the breakdown of the number of measures that are state collected on the left and clinic collected on the right, as well as the change in how we've organized and the number, the change from 2016 to 2023. For states, the number of required measures is not changing, although there is some change occurring in what is included in those 13 measures. Also, the last time we included 5 measures for states in the compilation of technical specifications, and they were not required. This time we are including 2 measures for states that aren't required, and we're treating them as optional for the states. For clinics, the number of required measures have decreased by nearly half, from 9 to 5. As with the state measures, there were 5 measures that are not required, but that are optional measures for the clinics. So for the clinics, there are 5 required and 5 optional measures that we'll be publishing. However, for CCBHCs that are part of the demonstration, it will be up to your state whether or not to treat some of your optional measures as required. The primary reasons for that are that existing demonstration clinics are already reporting 4 out of 5 of those optional measures because they were formally required, or they're currently required. They won't be required in the future. By us anyway. States may feel that some of those measures are important to keep reporting in order to assess trends over time, or just to make sure that the focus remains intact. So as you saw in the last slide, we published the measures and their technical specifications in 2016, and they have not been updated since. They are currently being updated, and there are multiple reasons that they're being updated. We needed to update the specifications for any of the measures that we retained from last time because the current specifications are extremely outdated. We wanted to strengthen our focus on access, including crisis response, social determinants or social drivers of health, and medications for opioid use disorder. So we are adding pertinent measures there. We wanted to reduce the burden on clinics by requiring fewer clinic reported measures. So we moved from 9 to 5 required measures for clinics. And we wanted to remove or make optional some of the existing quality measures that have either been problematic or that we had to remove in order to offset the addition of new measures, which we are filling gaps with, such as social determinants of health or medications for opioid use disorder. So I'll start with the clinic collected measures. The clinic collected measures are based on clinical data, so they are typically derived from EHRs or other electronic sources. So in other words, they are data that clinics house, that they have. For demonstration clinics, the clinic collected quality measures are calculated by the clinic and sent to the state 9 months after the end of the measurement year. For the CCBHC IAs and PDIs, they are calculated by the clinic and sent to SAMHSA. For clinics that are both part of the demonstration and SAMHSA grantees, which is, I think, a lot of you, we will discuss how this works towards the end, but you will have both reporting obligations. So these are the updated clinic collected quality measures. At the top are the 5 required measures, and at the bottom are the 5 optional measures. Very briefly, the time to services measures average time from contact to initial evaluation, initial clinical services, and crisis services. This builds on a prior measure, IEVAL, or time to evaluation. The second, depression remission at 6 months, is exactly what it says, measuring the extent to which depression had remitted after half a year. This reduces the measurement time from the old measure of 12 months, which was difficult. The third, screening for unhealthy alcohol use and brief counseling, is an updated version of the existing measure. The same for the next one, screening for clinical depression and follow-up plan, is updated from the existing measure. And then screening for social drivers of health is new. And I will be sending out some basic information about this measure in advance of it being published as a measure for you, because it is completely new. And I know many of you are already incorporating screeners into your EHRs. I will say it is a flexible measure that simply requires that the screener be standardized. There are certain things that it does require you to measure. It identifies a number of recommended standardized measures. This is taken from the MIPS measure, which is a CMS measure. And so you have options in terms of what screener you use, but I do want to get information out as soon as possible so that you have a little bit better sense of what that is. Again, these measures are the ones where the information is most readily in the hands of the clinics. And to save time, I won't address today the optional measures, but all of these, the required and optional measures, will be addressed in detail in webinars that we will be having in the fall. So moving on to state-collected measures. I got carried away with creating this slide. It looks like a sea urchin, but that's what it is. The state-collected measures are based on administrative claims, encounter, and pharmacy data, and to a limited extent, surveys already being collected. This is data that is most readily accessed by states. State-collected measures are calculated by the state for each CCBHC. This is for the demonstration, and sent to SAMHSA with the clinic results 12 months after the end of the measurement year. So this is slide 1 of 2, listing the state-collected measures. All of the measures on this slide are updates of measures that the existing demo states are already reporting. And I do want to note for all states that for all measures that are identified as based on the Medicaid core measure set, except for one on the next slide, these are among the Medicaid adult and child core set measures that will be required for all state Medicaid programs to report at the state level for 2024. Thus, all child core set measures and all behavioral health domain core set measures. Of course, these measures for us are reported at the clinic level. And this is the second slide of state measures, state-collected measures. Of the 5 measures at the top, all but the last 2 under required were already part of the demonstration. The last 2 required ones are new: the use of pharmacotherapy for opioid use disorder and the hemoglobin A1C control, that is new. The 2 optional ones at the bottom, I'm not going to go into in the interest of time, but we will talk about them as well as all others in our webinars in the fall. So I want to quickly touch on what we presently expect the timeframes for reporting to be. I said presently expect. I'm hoping this is what it is. So for all existing demo states and clinics, including clinics that are also in the PDI or IA grant programs, we are moving to a measurement year that reflects the calendar year, with the first year being calendar year 2025. This means that 2024 is going to be a transition year for you, and you will be getting more information on that hopefully shortly. For new demonstration states and your clinics, 2025 will also be the first year you report the new measures, and 2024 is a period for preparation, as is 2023. For any CCBHC IA or PDI clinics awarded SAMHSA grants in 2022, starting for measurement year 2025, you will submit to SAMHSA your most recent complete data no later than 90 days after the end of each 12-month grant budget period. So if you're also in the demonstration, you will do what the demonstration clinics need to do. But this is a way for you to get the data for the grants to SAMHSA without requiring much additional work on your part. So I'm hoping that's how it'll actually work out. And similarly for the 2023 awarded grantees, I do want to mention before I go any further, though, that there will be an updated reporting template for all reporters. So we will also have a webinar on that. So that was a lot of information, and I apologize if I delivered it too rapidly. We will have more webinars, however. So we will have general webinars in June and July. The one in June is on use of quality measurement for continuous quality improvement. So that's coming up pretty rapidly. And in July, we'll have a webinar to help new reporters with planning preparation for reporting before you actually see the new technical specifications. For the June QI webinar, it is most important that those who have significant roles in overseeing quality improvement be present for the webinar. For the July webinar, clinics should send a small collection of people involved in administrative, technical, and clinical oversight. We do ask that these contain no more than 3 people per clinic to avoid issues with access to the webinar. However, all of these webinars are going to be recorded for those who cannot attend and will be posted. It has come to my very recent attention that the National Council has one of its collaborative meetings scheduled right before or after the July 20th webinar. I have not yet decided whether I should try to reschedule this, but will determine that as soon as possible. However, it will be recorded, and it is most critical that a small group from clinics does attend this one. So you will be hearing more from me on that. Starting in September, we will have 5 webinars that are measure specific, dealing explicitly with the technical specification requirements. I am hoping to weave into this for each of them a little bit of rationale as to why it makes sense to use them and why it makes sense in terms of quality improvement for the clinics and the states. Starting in, well, I'm hoping that we have an approved reporting template by December for the December webinar. Otherwise, it will be in early 2024. So I have not, there haven't been any invitations or registration notices or anything sent out for the one starting in September. So that will be coming. This slide is just a preview of some of the ways that the measures have improved quality in the demonstration, which we have seen from the evaluation so far. They have helped to encourage same-day or open access. They've facilitated adoption of more standardized instruments by CCVHCs. They've led to workflow changes that ensure screening and follow-up, and have helped spur innovation in care coordination and service delivery. We will have a few existing demonstration states and clinics to share some of their approaches to using the measures for quality improvement on this webinar. And the third webinar, we also expect to have demo states and clinics to share some of their experiences on the third webinar. This slide includes just a few examples of things clients can do to start to prepare for data collection and reporting, such as working with your EHR vendor, working across departments that include IT staff, clinical teams, administrative staff to implement into the existing workflow, working to understand appropriate codes for billing and to record other aspects of performance, and to make use of the learning collaboratives that exist. So I have a second and final poll here that's designed to help you give voice to what may be causing you anxiety about quality measurement right now. So please select all that are contributing to how you feel at this time. Not knowing what the specifications look like, concerns about adequate workforce, worry that staff will not accept changes, concerns about cost, concerns that you might be judged negatively if your rates are low, math anxiety, anything else, please specify in the chat. Nothing, I am calm, cool, and collected. So I'm going to give you at least a minute to get those going. You can select more than one. I really want to hear what your concerns are because we're still planning future webinars. Selby, how are we doing here? I'll wait a few more moments. Selby, do we have a critical mass of responses? I hope we haven't lost Selby.
Nah, just check your chat. I sent you something.
Okay. All right. Okay. Okay, so the poll is apparently not functioning. Okay. So thank you to everybody who went ahead and put the numbers in. We'll tabulate those. Thank you so much. And I'll just wait a minute while you continue to let us know what it is that is concerning you. Ah, excellent. Okay. It's working. So it's calculating right now. So I will be able to share it in just a minute. Thank you, Selby. Everybody just be patient. The results are coming in. I think this is important, so I really want to wait and see what the results are. I apologize for the radio silence in the meantime. Okay, we're at 70, over 75%. Okay, I'm gonna end the poll, and Selby, if you could share the results. Oh, I'll share the results. Okay. I'll move this over. Okay. The major concern is not knowing what the specifications look like. I completely understand that. One thing I will say is for any of the measures that are Medicaid core measures, they are going to parallel almost absolutely the Medicaid core measures, the ones that came from those, both the adult and child. The MIPS measures will parallel the MIPS. I can tell you that. Concerns about having adequate workforce to provide care. Yes, understandable. I know we're in a workforce shortage and have been for several years at least. Okay. Worry that staff will not readily accept changes also is a big factor at 35%. That is why I want to try to weave into, I want to talk about quality improvement in the next webinar so you can understand how they can be used to benefit your practices, but also just to help staff understand why specific measures are being collected. Concerns about cost and concerns about being judged negatively. Okay, I want to address the judge negatively one separately and later, but that's good. There are a few of you who are calm, cool, and collected, so I'm happy for you. I think that you are probably ones who are already doing this, so I'm going to stop sharing the poll. Thank you, everybody, for that. Okay. All right. Let's move on. Okay. So now we have time for questions. I'm going to have Shweta read questions that are in the chat, and I will attempt to answer them.
So if we're not a demonstration state, do we only need to collect clinic measures?
So Shweta, you were kind of quiet. I'm turning up my volume. So the question was, I think, we're not a demonstration state. Do we only collect clinic measures?
Correct.
Okay, that is correct. If you are not in a demonstration state, if you are for instance, a grantee that is not in a demonstration state, you only collect the clinic measures, the five required ones.
When will the clinic collected measures technical specification document be released?
Okay. I am hoping to have all of the technical specifications out and available to everybody by the end of August, early September. And that's when we will start the measure specific webinars will be in the fall.
Any ETA as to when the new measures will be released?
In hopefully September, early September.
What clinical services qualify for the iServe measure?
That is the kind of question that gets answered in the specifications. The iServe measure has three parts. It has time from when somebody contacts you to the initial evaluation, which is something that's required in the criteria. And there is a time frame in there for that. And then time to initial clinical contact, and then time to crisis services contact. So it's obviously that third one's going to be different. But there is actually a fair amount of leeway, and we are going to probably in the specs give the states a little leeway in terms of what they may include as clinical services for that. In the past, when we did it with iEval, the one that's in place now, it was everything. And there were comments received about things such as one-time forensic evaluations and things like that. So that is something that that we're working on, and which we'll talk more about when we do the specific webinar for that measure.
Is the American Academy of Family Physicians SDOH tool acceptable for the SDOH measure?
I do not have the specification in front of me, but the specification includes 5 well-known measure screening instruments. It's very possible it is one of them. I wish I could answer you off the top of my head, but that is what I'm going to be getting out to people. I want you all to know what that measure says so you can plan accordingly, and I'll try and do that as rapidly as I can.
When can we stop collecting some of the optional clinic measures in the new criteria? Is that up to the state if we are a demo site?
Yes, that is up to the state. I mean, in terms of the measurement for the new, using the new updated measures will commence for the year 2025. So in the meantime, you're expected to keep reporting. So not until 2025. And then in terms of the ones that are going to be optional, it is up to your state to decide if they want to continue for you to use them.
Can you be more specific about the July 20th webinar attendees?
Mm-hmm. Yeah. The July 20th webinar, which could end up getting rescheduled, is designed to provide an overview of the types of logistics that are important to plan for, think about, and begin preparing for as you prepare to collect the data and report these measures. So some of the things that we have learned from the evaluation in the past is there's an immense amount of work that needs to be done in terms of working with your technical people and with your EHR vendor. There is training that needs to happen with your staff. Often that's clinical staff, to make sure that, for instance, if there is a specific instrument that's required, that it is in place and that they can collect it, and it can be done in a way that doesn't interfere with your other work that you're doing. So those are the sorts of things that that July webinar will be talking about. So it's a combination of like administrative management, organizational types of things. It is clinical, integrating things into the clinical workflow, and then IT integrating things into the EHR to other systems that you have.
For non-demonstration states like New York, are only the 5 clinic required measures needed to be reported? We are a newly granted GY 2022 CCBHC PDI.
New York is a demonstration state, unless my memory is not serving me correctly. So if you are a new grantee that is not a demonstration clinic, if you're not an existing demonstration CCBHC, New York will, unless you become a demonstration clinic, in which case New York will have say so on that. If you are just a PDI or IA grantee, you only report the 5 required clinic measures. I hope that answered the question.
How are you considering the process of reconciliation of timeline for grantee reporting? The measurement year is January through December, but most grantees are operating on an October to September year.
Mm-hmm. This is complicated, and we're going to be getting a transition memo out that will try to help you with this. I can explain to you why we're going to a calendar year. In the past, it was the demonstration year. And when the demonstration began in 2017, and there were 2 states that have been added since then, there were different demonstration years. There were demonstration years all across the calendar year. And as we are now going to be adding more demonstration states in 2024 under BSCA, and the expansion grantees will be reporting, it becomes increasingly complicated to try to make this uniform. And we needed to make it uniform. So the calendar year is what we are using. I will say for the states in particular that the calendar year is what's used for the Medicaid core set and for a number of other sets that are reported by states. So the work that you're doing in preparing for this as a state will parallel what you're doing in preparing for reporting the core set in for 2024, actually.
If a state is currently reporting data on a July through June measurement period, how will the requirement to switch to January to December affect the mid-year period? For example, July 1st, 2024 to June 30th, 2025 would fall into both periods.
Mm-hmm. Our transition memo will address that. We're still finalizing it, so I hesitate to say anything because I could be wrong.
Excuse me, Peggy. I'm
Yes.
not sure if you're seeing the chat, but they can't hear her.
They can't hear Shweta?
So if you want to repeat portions of the questions so that they're able to understand what you're answering, that would be helpful.
Okay.
Or I pick up where she left off. I have to find, I'm not sure where she left off, but.
Okay. All right. Shweta, can you try and speak a little bit more loudly, and I will try and repeat questions.
Yeah, I think it's her mic level.
Okay.
Can you hear me better now, or is it the same?
I think it's a little better.
Okay. Do you want me to continue, or Selby, do you want to pick up the questions?
Ask the next one because I have to track where you are, and then I can pick up if need be.
All right. Can demonstration states continue to collect the suicide and suicide attempt measures moving forward?
Okay, so the question is, can the states continue to collect the suicide and suicide attempt measures going forward? If states are already doing this, this was not required in the past. You are welcome to, to continue to collect it. We will not be providing reporting templates for it. You can continue to use the existing one if you wish to, but you're free to do that as you wish.
I changed to my headphones.
Much better.
Okay, all right. I can continue. How often do PHQ-9A for children/adolescents need to be collected?
That will be in the specifications that'll be coming out, and we'll talk about that in the appropriate webinar when we discuss that measure. However, if you look at the Medicaid core set, you'll be able to determine that.
Will state quality measures come from claims data at the state level, that is follow-up post-discharge from ER?
Mm-hmm.
Clinic data has been unreliable based on client reports.
Right. The idea is that the follow-up measures are required of the states because the states have access to data that the clinics do not easily have or do not have at all. So in order to be able to determine if a given, say, Medicaid recipient who was seen in the emergency department or seen in the hospital for substance use or mental health issues has follow-up, the measure uses the Medicaid claims and encounter data. So that is what the state will be using.
Regarding the reporting template, seems like the question is, do they know if we'll be entering it in SPARS or a document submitted via ERA?
For those of you who are SAMHSA grantees, the PDIs and IAs, it will not be SPARS because SPARS is not set up for that. It would be part of your annual reporting through ERA.
When will SAMHSA report out on aggregate data for comparison?
There is an ongoing evaluation that is being conducted by ASPE, the Assistant Secretary for Planning and Evaluation of HHS. This evaluation's been going on from the very beginning, and there are, they have, to the extent that they've been able to, have used quality measure data in aggregate in the evaluation reports. The evaluation reports are public. They are available on the ASPE website, ASPE, Assistant Secretary for Planning and Evaluation. It's part of HHS. And if you go there, I think they have a resources link, or you certainly can search the site. And if you put in CCBHC, you will be able to find all of the evaluation reports to date. And the evaluation will be continuing as the demonstration continues.
Okay. When are we informed about which measurements which measurements states will adopt?
Okay, the states will be required to report all of the 13 required measures. So you know that. In terms of the 2 optional ones that they have, that is up to the states to decide. If you're a demonstration state, it is going to be up to your state to determine if you're also going to have to report any required, non-required, optional clinic reported measures. We have not imposed a deadline on the states to make that determination. I think the states will probably need to think about it and plan and make decisions.
We got granted PDI on 9/30/2023. When do we begin collecting, and where and how to report?
Okay, there's going to be a lot more information coming out about this. Over the next year, you will be actually preparing for it. And that's what these webinars are to help you do. The first measurement year will be the calendar year 2025. And there will be work that you are going to definitely have to do during 2024 to be ready for that. That is why I'm hoping that you'll tune in for our other webinars as they come up, because I'll be able to give you more information than I can on this general webinar.
For expansion grantees, how will SAMHSA collect the claims-based data and outcomes, since providers will not have access to that claims-based data?
Could you repeat that, Shweta? I'm sorry.
Sure. For expansion grantees, how will SAMHSA collect the claims-based data and outcomes data, I'm assuming, since providers will not have access to claims-based data?
If you are a grantee, an expansion grantee, and you are not in a demonstration state, there is no requirement that what we're calling state collected measures be collected. So you do not need to worry about that.
And someone wants to confirm for new CCBHCs, PDIs and IAs grant year 2022, that their first report would not be due until 2025.
2025 will be the first measurement year. Yes. Yes.
Someone's asking to clarify again when they should stop collecting the old measures.
Continue until you're told otherwise. There will be a transition memo coming out that will help clarify this.
Will SAMHSA provide an FAQ for the webinar series?
I think that because we have all of these questions in the chat, that it'll be possible for us to go through them and assemble them into FAQs. And I think that as we get into the webinars that have more substance, that are not as general as this one, I think there definitely will be. Yes, and during the inception of the last the original demonstration, there were quite a few questions about quality measures that came up as people were implementing them. And we will be compiling, we called them clarifications, but we will be compiling them. My goal is to have the same general information available to everybody who needs it.
Someone's asking for clarification that SAMHSA won't be providing a reporting template for non-required measures. And they're asking if that's correct. If SAMHSA won't be providing a reporting template for non-required measures.
The measures that are optional for both the state and the clinic that are on the list that I showed you, there will be a template for those. Someone asked a little bit earlier about measures that were never required, the suicide and suicide attempt measures that were in the old set. We are not going to maintain a reporting template for those measures that are, I'll just say, disappearing from the behavioral health clinic measures. But anything that we have listed as either required or optional for the measures that will go into effect for 2025, you will have a reporting template.
Someone's asking, will you address reporting burden for CCBHCs that are both state demonstrations and also IA CCBHCs?
To the extent I can, I'll try. We work to alleviate burden by cutting back the number of measures that are required of clinics. And that was one of my primary foci as we updated the measures. And we really want to reduce burden. So let me just say that the primary reporting requirement, if you are a demonstration clinic, is that you report at the time and in the way that all demonstration clinics report. If you are also a grantee, you will be submitting, I believe, on ERA Commons, along with, or the same way you would report your annual report, whatever data you have most recently available at that point when it's due. And that is designed to hopefully minimize the amount of burden that being in two roles places on you. There will be more information in the transition memo coming out for those who are both.
Someone's asking, was there a public comment period when SAMHSA was considering these changes to the set of CCBHC metrics? If more changes are made in the future years, how can we make sure to stay informed about any opportunities to comment?
Okay. The CCBHC certification criteria that apply to all CCBHCs, including the grantees, the discretionary grantees, were updated in March of 2023, and it did go through a public comment process. And that document identified what the updated measures would be. And so people did have an opportunity to comment. Also, in the process of determining what updates to include, I did participate in some National Council sessions that were already scheduled with existing demo states and clinics to get input from them. So that was another way in which I gathered information.
They're asking, will all grantees in a demonstration state become eligible for PPS?
You have to be a demonstration clinic certified by a demonstration state. So your state has to be selected to be a demonstration state, and they have to certify you as a CCBHC for you to be part of the Medicaid program PPS. Please let me know if that's not clear. I'll try and restate it.
All right. So will GPOs receive training on quality measures to help grantees address individual questions as they arise?
I am trying my best to keep the GPOs informed as these webinars come out. I'm sharing with them beforehand. I will be providing, I am available to the GPOs if they have questions. They will be as trained as they can be, and there will be avenues for anybody who is reporting to ask questions. It may not be through the GPOs. It may be through a mailbox. We have had several CCBHC mailboxes for the demonstration, and we're still trying to determine what the best approach is for that, but there will definitely be an avenue for questions to be answered about implementation of this. And I think that we're probably out of time. I appreciate everybody coming to this webinar. I hope that you will be able to attend the later ones. And the next one is June 1st on quality measurement for continuous quality improvement. Thank you, everybody.